Welcome everyone to the Obesity Matters Wellness Workshop, where we embark on an incredible journey together towards better health and wellness. Whether this is your first time with us or you have been with us since the start of the program, we are grateful you are here. My name is Rachel. I am the Vice Chair of Obesity Matters, and I am your host for this year-long program. Today, we have a rather hot topic. In fact, it's in the news daily, and we heard from you that you want to know more about it. The topic is medications. Today's session is titled Uncovering the Facts About Anti-Obesity Medications.
Obesity is a chronic disease, just like diabetes and high blood pressure. And so we're treating a chronic disease with medications that target the specific underlying biological cause. And I think that's the most important way to really understand what these medications are doing. Because if they're simply just making you eat less food, for example, or simply an appetite suppressant, then that's not actually going to improve outcomes better than diet and exercise, unless we're actually treating the underlying cause. So what are obesity medications? They are targeted therapy, typically in the brain, that help to regulate different biological processes. Those can be things like our appetite system. That's regulated with medications in the class called GLP-1s. That's a hormone that's made in your stomach in response to food that goes to your brain and regulates hunger and fullness. There are medications that work more on reward and pleasure seeking. These are medications like Appropion, naltrexone. They work on a totally different area of the brain that regulate pleasure and reward we get from eating certain foods. There are other classes of medications that work to increase metabolism or are in the class of stimulants. Those are not actually approved by Health Canada, but are available in the States. So Jonathan can speak to those in more detail. And here in Canada, we essentially have 3 Health Canada approved medications to manage weight. The GLP-1 class, that is Saxenda or liraglutide at 3 milligrams, or semaglutide 2.4 milligrams, the trade name of which is Wegovy. We don't actually have Wegovy available, but we do have that approved under Health Canada. That's the same medication that is in Ozempic, which many doctors prescribe technically off-label. Ozempic is also semaglutide. These fall into the GLP-1 receptor agonist class of medications that mainly regulate appetite at the brain center, as well as insulin resistance and other hormonal pathways. Then we have Appropion naltrexone that regulates mainly cravings. And lastly, we do have another medication called Orlistat or Xenical. This regulates fat absorption in our gut. It's not something that actually we prescribe very often, mainly because it has a lot of side effects with diarrhea and stomach upset, but it's also not treating the underlying biology. Because obesity is a chronic disease that is centered in the brain, truthfully, unless the treatment is targeting that brain pathology, we don't typically see enough benefit with these medications, and most importantly, long-term benefit. We see short-term benefit and weight regain. So that's just sort of a summary about what medications are and how they work.
That really kind of just opens up the idea that patients really sometimes don't think you need medications and that we should be doing this just by diet and exercise alone. So the question of, what are they really kind of goes along with why in the world do I need these things that are out here? And as Megha pointed out about all these various mechanisms, the difficulty with obesity is not only is it a chronic, progressive, relapsing disease, just like any other problem, just like any other major chronic medical issue, but it's also way more complicated. So even though, yes, absolutely, we do know that it's centered in the brain, and we could discuss selling points and things of that nature and how that is overall affecting our relationship with food and energy balance. But there's so much more than that, right? I mean, there's so many different causes, there's so many drives for why we eat, the decisions that we're eating, energy balance, things that are causing issues with, even from a genetic standpoint. So there is not a one size fits all kind of medication for any particular person. And this is just like any other treatment, right? Like there's, I get patients that will tell me like, oh, just give me that shot, we'll be good to go. And it's like, well, that shot, which typically we're talking about, semaglutide in this case, or liraglutide in this case, that's not always the case that you can do one particular thing for a patient and that completely resolve everything. So obesity medications are meant to be personalized medications to treat root causes, whether that be overall hunger and appetite issues, maybe that is problems with insulin resistance, maybe that is hedonic and pleasure eating, which Megha spoke of, particularly with Wellbutrin or bupropion and naltrexone. In the US, we also have Qsymia name brand, which is phentermine topiramate combination, and that's also approved for chronic treatment. And, again, works in a different way. Yes, primarily in the brain, but also might have some other mechanisms in terms of metabolic function and possible lipolysis there. So the big kind of question is, once you see that obesity is like any other chronic problem, and we know that once you bite that bullet and you get like, look, this is it, right? It's just like any other problem. Of course, we're going to have medications that are going to treat that problem. And of course, you can sit down with a specialist, talk about it, and figure out, okay, what in the world's happening? And let's treat these root causes like we would anything else. And even though we have multiple options, there is always typically something that is going to fit that particular pathophysiological issue that's going on with that particular patient. I'll give you the scientific appropriate answer, and I'll give you a little bit broader answer, but typically the indications are if your BMI is 30 or higher, or your BMI is 27 and you have some associated comorbidity, right? So if your BMI is 27 and you have insulin resistance or hypertension or dyslipidemia or something that's going to be associated with that, which may be mechanical as well, osteoarthritis, low back pain, some associated comorbidity. And the other kind of thing that we think about are anytime you talk about this to an audience, it's people who have, tried lifestyle interventions and have failed them, people who have lost weight and then previously also regained it. That's everyone, right? So I get a little kind of irritated sometimes when, if I'm giving a lecture to physicians and yes, you look at the guidelines and they always say, oh, make sure somebody's failed lifestyle treatment and make sure somebody's has struggled and they can't maintain their weight loss. Well, over 90% of people who lose weight gain their weight back. So literally that's everyone. In a broader context, just from a clinical perspective and kind of apart from guidelines, anyone who is struggling with their weight within reason, BMIs are useful categories because they're generic enough. Our EHRs calculate them. They're easy math to do. Although there are this has been a hot topic with issues with BMI in general, because most of that data is on Caucasian males, essentially. And so that it does become more difficult to just use BMI, even though it is a good, decent, generic kind of thing. But I could put somebody on a body composition machine and their BMI be 25, 26, but have significant elevated body fat percentage that would fall into obese category, have high visceral fat content, and have difficulties with metabolic arrangements secondary to that adipose tissue. And so some of that, I just want to say, there are some guidelines that, yes, need to be followed. And no, someone with a BMI of 22 does not need to be treated with an obesity medication at all. That's also something that we have seen with, at least in my area, GLP-1s being thrown inappropriately left and right to somebody who does not need them whatsoever and actually tends to run into sarcopenia and a whole bunch of other issues because they're just inappropriately being treated. But I am saying that because obesity is a chronic medical problem, because it's so complex, because it is a probably more complex and complicated medical issue than we deal with in our other stuff, that medication should probably be used way more than it currently is, right? So the data has changed where it used to, we used to say only 2% of people that are appropriate for obesity medication being treated. We're up to a whopping 3%, right? So we are just doing amazing. We went up 1% in terms of treatment. And part of that is because of bias of using medications, because we should just be telling people, if you just buckle down, and get it together, then you'll be fine. Or patients will tell me I lost 50 pounds a few years ago, and then I just fell off the bandwagon. And it's like, well, you didn't, because 92% of the population also does that. So clearly, this is just indicative of the fact that no one can keep it together, right? Because keeping together is not a thing. Technically, 27 with comorbidities, BMI of 30 is the current guidelines, with my caveat of let's treat people like we would anything else, right? I mean, I may tell somebody with high blood pressure, don't drink, don't smoke, don't salt your food, walk 7 miles a day, pray all day long, keep yourself calm, do all of those things, and your blood pressure might get better by 2 points. But yeah, you're going to go on blood pressure medicine because takes that appropriate treatment to get there, right? So
this all boils down to the definition of obesity. And so if BMI is a population-based definition, it's not for the individual person in front of us. And so what I think the point that we really want to hit home is that all people deserve treatment. They don't have to jump through all these hoops to be able to get treatment. That's not effective management of a chronic disease. The definition of obesity includes BMI, but it also includes waist circumference, and it also includes how much this weight is impacting your mental, mechanical, and metabolic health. And so you can be at a lower weight and be carrying a lot of weight around your stomach area, which internally means that you have fat around the organs, putting you at higher risk. You should be treated. And so I think the conversation is ask the question, make sure you're getting the right workup, because there is a workup involved in the conversation. It's not just putting you on a scale and deciding whether medication makes sense for you. And I think we need to start doing those things because insurance companies don't have those criteria. I can say you need medication, but that medication may not actually be available to you because of a systemic problem with using just the BMI as the base. And I'll just share where that's coming from. That's coming from the clinical trial. So when they test these medications on thousands and thousands of people, you are only allowed to get that medication if you meet that BMI criteria. So now if you fall into a different category, I don't know safely what your side effect risk is because you never entered that clinical trial in the first place. And so that's an important understanding just from a patient perspective, is the reason why the barrier exists is because all of the roadblocks have been set up that the diagnosis of obesity is based off BMI alone. Until we start changing research, start changing the questions that we're asking about how we're defining obesity, we're not going to be able to open up these doors safely. However, if you meet the right doctor who's an obesity doctor and is able to talk you through some of these things, I still think it's important to ask the question, but you probably will face barriers to actually getting access to that medication for all those reasons. The basic understanding, if you accept that obesity is a chronic disease, just like diabetes and high blood pressure, and you understand what these medications are doing to your biology, it becomes more acceptable in that you do need to stay on these medications long term. So most of these medications are improving an let's say appetite system that's regulated in the brain. That's a biological problem. Every time you lose weight, your appetite system makes you more hungry and less full. When you take these medications, for example, the GLP-1s, they are regulating that problem. So what they're allowing you to do is be full on smaller amounts of food and keep your weight down long term. But they're only going to do that as long as that treatment is there. Once you stop that treatment, your biology will just go back to the same place it was before. And it's the same as, for example, treating a thyroid illness. And the reason I make it similar to thyroid disease is because it's a hormone, just like GLP-1 is a hormone. When you have an underactive thyroid, your body, it will wreak havoc on all the cells in your body. You treat it by taking the thyroid hormone and everything levels out. But that doesn't mean your thyroid all of a sudden starts to work normally. When you stop that medication, your thyroid is still dysfunctional and your levels will drop back down. So it's the same with the GLP-1 or this family of medications. It's the same with any treatment, whether it, an exercise plan, a nutritional plan, meal replacements. You do need to do something long-term because this is a chronic disease that it is something that you will sort of consistently need to work at. Most of the data that we have around medication is actually not that long-term, right? So this is the next step in this world of obesity medicine, is doing studies that are what happens after 5 years, what happens after 10 years. We treat patients in our offices and we sort of see what happens. And I would say that being on medications is far more effective than not in terms of keeping weight off long term. But we're still waiting to see in a big clinical trial, what does that look like after 5 years? And what does that look like after 10 years? The really good thing about the GLP-1 class of medications is we've been using them for a long time. These are not new medications. They're used in the treatment of type 2 diabetes for almost a decade. So I think a lot of the concern around staying on medications long-term is around safety. And why we feel so comfortable prescribing these medications is we know they are safe because our patients living with diabetes have been on them for a long, long time. And I would say in majority of people, the benefits of these medications far, far, far outweigh the risks of being on them long-term from what we know so far.
Yeah, I'm not sure if this could even be addressed here, but one thing that I find very frustrating. So I had gastric bypass surgery in 2019. I've lost 130 pounds, but it hasn't been easy, and I am still on Ozempic. And yes, obesity is a chronic disease. It's not like, oh, I've lost weight, I can just carry on now. And I'm still taking metformin, even though I'm not technically type 2 diabetic anymore because I have PCOS. But because of all I'm blaming it on all the marketing that the drug company has done and the Kardashians and everything else. Ozempic now is not covered anymore. And a lot of people they're not getting covered unless, so I've been on it since 2017. And now all of a sudden it's not being covered. I have to jump through all these hoops. I have to fill out a special authorization I'm in British Columbia, so it's from British Columbia, but I know it is the same in other provinces. And it's not going to happen for me because what you have to prove on this special authorization is that you have type 2 diabetes and your primary other medication is not working, and so you have to have Ozempic on top of that. So I won't qualify because that they're going to say, no, you don't have any issues. But the point to what you've all said here is, yes, it's a chronic disease. Sure, I can stop taking these medications, but the weight's going to come back regardless of the fact that I, had surgery, and yes, I'm exercising, and yes, I'm trying to eat right. But the bias is still there that it's your fault, you're doing something wrong, like Jonathan said too, like you're not doing XYZ even, So what are we doing? Like I know Obesity Matters is and Obesity Canada, and there's different things, like we need to advocate or something, like what, I'm just wondering where we are with that or what we can do to get this message out there and get some help.
We've had an insurance company. So for example, what was happening previously is that all employers had to opt in to obesity medications, meaning that they had to actually advocate and step forward and say, yes, I will cover these for my employees. Now we are starting to have insurance companies saying you have to opt out. That's a huge thing, right? Because for somebody to go proactively and say, no, I'm not going to cover it, that's going to be far, far less than just going in with all the other chronic disease medications. That was a really, really good step forward. The other thing that Jonathan was talking about was the SELECT trial was a trial with semaglutide 2.4 milligrams Wegovy, looking at does it decrease the risk of heart disease in people that have already had a heart attack or a stroke or have some sort of heart disease. And the top line results that just came out in the media was that it reduced that risk by 20%. And so what Jonathan was saying is that, and this is where I think things are going, is it's not going to be an obesity medication. It's maybe going to be an obesity plus heart disease medication. And so, that there's pros and cons to that because there's still going to be lots of people that need therapy that aren't going to get treated. But where the door, I think, I agree with Jonathan, is going to start opening is, do you have fatty liver disease? This medication treats fatty liver disease. Do you have heart disease and obesity? This medication reduces mortality because dollars. At the end of the day, all the insurance, and like we're right out there, Dana, with you talking to these insurance companies, talking to the government, trying to understand the economics of it, because it really just boils down to dollars and cents. And we still continue to get the feedback that they're too expensive. The medications are too expensive, and the outcomes that we're seeing actually don't make it worth it. So shockingly, even though you can imagine all the benefits just with quality of life and metabolic health, the numbers still have not shown that. And now with mortality, so that's like years of life, that is an expensive thing, and heart attacks are expensive things. So that's where I think the real rational conversation is going to go, because there is so many biases and so many hurdles. But unless we make the dollars and cents speak the language that they're speaking, I don't think that we're going to see that. But it's going to be, I think 2024 is going to be a really great year for people living with obesity, because we're now getting these trials that are showing these positive outcomes. conversation is an interesting one because I'll start by saying everybody is different. And just like any other medication class, everybody's benefits from these medications are going to be different. And we see that right across the spectrum of all the different medications and all the different studies. There are some people, if we're just going to use weight as the outcome that we're looking at, there are some people that lose a significant amount of weight. We call them super responders, higher than the average person. Majority of people will lose sort of in the middle. And then there's some non-responders, people where this medication really isn't improving their outcomes when it comes to weight specifically. All the different classes of medications are a little bit different in terms of what the average weight reduction is. Whenever anyone quotes you a percentage weight loss, what they're talking about is how much you're going to lose, the expected weight losses in total from your starting weight as a percentage. It's always on top of lifestyle changes. It's always on top of dietary and exercise plans because all the studies showed that. With liraglutide at the 3 milligram dose, the average weight reduction is usually around 8%. With semaglutide, it's close to 2.4 milligrams, it's close to 16%. With tirzepatide, it was around 22%. So you can see the newer classes of medications, the average weight reduction is far, far greater. With bupropion naltrexone, that's Contrave, that works more on reward and pleasure. The average weight reduction is around 7 to 8% with diet and exercise. That's kind of like just talking about weight reduction. Now, many of you might be sort of saying that's not a lot. And that's because the idea behind obesity treatment is it's actually not about weight loss. Most people think weight loss and obesity are the same thing. They're absolutely not. Obesity is treating an overlying biological problem that's causing other health issues. And so, it's a really difficult conversation around expectations because if you're defining success as being this many pounds, then most likely you're going to feel like this treatment's not worth it. But if we can take a step back and redefine what are the actual outcomes that you're looking for here? What is it that your weight is stopping you from doing, or what are the health problems that it's causing? And how is this treatment improving that? And when you start looking at things that way, it becomes much more realistic to stay on treatment long term, but also much more motivating because we actually don't have very much control over how much we weigh. That's a biologically, genetically predetermined thing. The patient sitting in front of me and me, I can't predict where your weight's going to land. So I'm not going to use that as the be all and end all of, what we're trying to do here. But what I can try and do is help you feel better, help you sleep better, help you move more, whatever the goals are that you want to work towards to help improve your quality and quantity of life. That's what I sort of look at in terms of what we're trying to do. And the weight is included in there, but not sort of the priority of the treatment plan.
And sure, as you pointed out, currently, if you look at the data, tirzepatide's, about over 20%. We've got 17% with Ozempic and semaglutide. We've got about 12, 13% with liraglutide. In the United States, we have phentermine, topiramate, which is about 9-ish% of weight loss, and then kind of going on that. And that's good to know. It is good to know that there are, just from a blank weight loss perspective, there are more effective medications and less effective medications. But generally, if I'm asking someone, and I have patients often fill out paperwork before they come to clinic, and I will ask them their goal weight, and not actually because I care about their goal weight at all, but to get where their mindset is. And it is always shockingly, I weighed 98 pounds in high school. I'm using pounds, forgive me, So therefore, I should be at X amount of weight. I only say that, patients think that I'm going to then follow that up with, well, great, let's calculate how long this is going to take to get to your goal weight. We're going to be happy. But my follow-up is, why this? Let's talk about expectations. Clinically, we know that 5% makes substantial difference in blood sugars and triglycerides and blood pressure. You get health benefits from 5% of weight loss. Some things takes a little bit higher. So we know there's clinically significant improvement, even when there's not these huge, gigantic weight loss. And a lot of that just comes down to how we have framed weight for the last 50 years. It goes in line with the bias. It goes in line with 100% on patients. It goes in line with all of our wrong-headed societal norms in terms of all the things that contribute to dysfunctional relationship with food and self-image and all of those things. And being able to finally just kind of think, okay, why in the world do I want to lose weight in the first place? It's never for weight's sake. It's always for something else. As Megha pointed out, maybe, it's because you want to be able to play with your kids or walk around the block with your grandmother. But particularly, and I've seen this more and more in patients being concerned about, oh my word, my A1C is out of control, and being able to say, well, great, you might have only lost 2% of your body weight, but your A1C is down 2 points. Like, that gets me excited. Like, that's amazing. That's an exciting thing. When you really spend the time and talk to patients about what's happening, and they understand that, as Megha pointed out, obesity is extra adipose tissue that contributes to health concerns and health problems. That's actually what obesity is. Weight's a completely different thing, right? Weight is not necessarily related to metabolic and mental and mechanical dysfunction. And so being able to get patients excited about, let me walk through your numbers and see what's happening. When we initially talked about this, remember your triglycerides were really high when we initially started talking about this. Look at what your triglycerides are doing. Look at what your waist circumference has done. And let's reframe what we are doing here. And I've found that the more I talk about it with patients, the more they get excited about those things too. Because if you don't, you lose your external motivation and your internal motivation, right? So you lose motivation if you're so hung up on number on a scale, and that number on a scale is dropping very slowly, you're going to lose your motivation and lead into possibly a self-spiral and have difficulty, controlling it. When you shift your mindset towards, is my A1C dropping? Is my blood pressure improved? Did I come off of medication? All of those other aspects allows for continuing motivation. Sometimes I will just look at somebody's labs if I feel like they're starting to struggle and say, look at this. Look how amazing this is. Look how, look what you've done. Look at this, this improvement. And they're like, all right, okay, I get it. This is good. I like it. All right, now we got some more motivation again. And we can kind of keep on going. So that's the big shift, is just getting away from selling weight loss and trying to treat obesity.
Well, it's great to hear that from both you and Megha. It's one of our core beliefs here at Obesity Matters is that it's not about the number on the scale, right? It's about improvements to the quality of our life.